recognizing that the didactics are really designed to be about 15 to 20 minutes, I opted to break it down by drug class. So for this one, the focus is really just going to be on antipsychotic medications and their chronic adverse effects. I didn't think I could do justice to more than one drug class within the 15 to 20 minutes. So we can revisit this later with the other drug classes. So objectives, we're going to identify the adverse effects that are that most often result in discontinuation of therapy. The focus is going to be on children, adolescents, and adults. I purposefully excluded individuals who are geriatric, mainly because most of the folks that we have calling in do see more of the children and adolescents, and there's some different considerations once you introduce the geriatric population. So we're really going to be focused more on the younger folks, the younger patients. And then we're going to compare the differences in adverse effects between the antipsychotic medications. So to start with, if we're considering long-term adverse effects and chronic exposure to these medications, is it realistic that they should be on them long-term? The answer is yes. So this is a list of our second-generation antipsychotics with the addition of haloperidol and what their FDA-approved indications are. In most cases, with the exception of some of the acute agitation indications for the short-acting injections, these really are designed for long-term treatment. In some cases, the longest data we have may only be 12 to 24 weeks of therapy and exposure, so that will be the long-term effect. But many of them really are designed to be put on board and be treating patients potentially for years. So it is very likely that you may encounter patients that have been on any of these preparations for an extended period of time. Despite the fact that the indication may imply that they should be on treatment for a long time, we don't tend to have patients that stay on their oral antipsychotic medications long term. So the CATIE trial is a little bit dated now, but it was a national study that was done really looking at a naturalistic course of treatment with the antipsychotics. It went for 18 months, and the first set of bars there is the total discontinuation rate. So by 18 months, more than half of the patients had discontinued for one reason or another. Now the blue bar, the one that's the farthest on the left-hand side, that's for olanzapine, or your Zyprexa. It actually had the lowest total discontinuation rate, which I think is important to highlight, because when folks think of olanzapine, they may think of it as being really side effect burden heavy, but it was one of the ones patients were more likely to continue on, significantly more so than all of the other preparations. For this particular national study, they did use perfenazine, that's that bright green bar. Perfenazine was their first generation comparator. So why did they stop? So why did more than half of these folks stop their medication? Some of them, between 15, well, really more around about a quarter of the patients that were not on olanzapine stopped their medication because they were not receiving the amount of efficacy that they wanted for treatment of their psychotic symptoms. So olanzapine was seen to be significantly better. So they were not dropping out because of efficacy in that particular group. One thing I do want to point out, so with the quetiapine, we may have been slightly underdosing that. Since the CATIE trial has been completed, the doses of quetiapine have gone up a little bit higher, so that might be inflated a little bit, but it was still pretty consistent with about a quarter of patients were not responding. We're going to spend most of our time focused on tolerability. So the tolerability data for the CATIE trial is interesting because risperidone actually was the one that was the best tolerated. Those patients were least likely to discontinue their medication because of adverse effects, which again is a little bit interesting. You wouldn't think of that as being really side effect neutral, but they tolerated that one incredibly well. And then for patient decision, the olanzapine was significantly better than both the quetiapine and the ziprasidone. It did not differ from risperidone or perfenazine. So what does this mean? This means that there are inter-individual differences in how well patients respond to the medications, and just because of what their side effect burden may look like, that may not guarantee whether or not a patient can tolerate the medication or not. I also wanted to look just a little bit broader at all-cause discontinuation. So this was a meta-analysis that was published in 2013, and it looked at a number of different trials for both the second generation and more of the first generation. So you see haloperidol is added on here. So the line of 1 comes across the top. That really is the difference line. So above 1, it would be more discontinuations with the antipsychotics. As you see, all of these are underneath 1, which means that there were more patients that discontinued placebo than there were that discontinued the antipsychotics. So all of them were significantly better for long-term treatment than the placebo group. That includes both for side effects as well as for efficacy. Between the groups, though, you see that there's kind of a gradual progression. So for some of the medications, haloperidol being one of them, they may be more likely to be discontinued than some of the other agents. But consistent to what we saw previously, both olanzapine and the risperidone are on the end that seems to be a little bit farther away, where they were better tolerated and patients were willing to stay on them long term. So in thinking long-term treatment, it is worth going back to investigate how those medications are working for the patient. So are they having any side effects? Is it doing what they hoped that it would do? And are there any new concerns about it? Because even though it works right away, they may not stay on it long-term, or if they have side effects right away, they may get adjusted to them and then be able to stay on them long-term. So the reasons that they did discontinue, there are 2 main ones that we're going to focus on. The most significant reason for discontinuation of tolerability, what would that be? It's weight gain. So we'll focus a little bit more on the second generations, but this tended to be one of the reasons that patients would stop taking their medications. In looking at that CATIE data, that national study, what we see is, this is skewed a little bit, but the blue bars that fall onto the left-hand side, that was actually the percent of patients that lost weight after they started a medication. The green bars to the right are the percentage of patients that actually gained weight from baseline once they started the medication. Now, I do word of caution, something like risperidone that's right there in the middle. So it looks about 24% had lost some weight, about 24% had gained some weight. It may have, that weight loss may have had something to do with the treatments patients were on previously. So if they were on a medication that was making them gain weight, they had a week or 2 of washout, and then they started, they may not be losing weight because of the risperidone. They may be losing weight because they're not exposed to whatever the other preparation was. So I do just want to have a word of caution on the weight loss side. On the weight gain side, there is a significant difference between the different agents, with olanzapine demonstrating the most amount of weight gain. So about 42% of those patients were gaining weight, a significant amount of weight from their baseline. But even medications that tend to be thought of as weight neutral, things like perfenazine, which was our first generation, and ziprasidone, which is the Geodon, there still are patients who are gaining weight on them. So it is something that's important for us to continue to revisit. Another consideration with the weight gain, in some patients they gain weight right away. So you started to see that right away. In some of the patients it leveled off. They gained some weight and then they didn't gain any more. There was another group that gained weight right away and just kept gaining weight. It's really difficult to be able to identify these patients, but if we see weight gain right away, we definitely want to continue tracking that. If we don't see weight gain right away, it doesn't mean it won't happen. It may happen a little bit later, so it is important that we go back and revisit this. So looking at more than just the agents that were included in the CATIE study, what we see is 0 is the bottom line across the x-axis there. That would be no weight gain. all of the antipsychotics, and I want to say this again, all of the antipsychotics can cause some degree of weight gain. It does not matter if they're first or second generation. The amount of weight gain that we may see is significantly different. So agents such as haloperidol and ziprasidone, which are on the far left side, tend to result in less weight gain than what we see with agents like clozapine and olanzapine, which are on the far right side. Not a huge surprise, but there are patients on haloperidol that may gain more weight than what they would gain on olanzapine. So there is an individual component to this as well. We can pick an agent on this range if a patient's really concerned about weight gain and they don't want to gain weight. Starting in the middle or moving toward the left-hand side of the graph, those would be the agents we would want to start them on. But from a credibility standpoint, it really is important that patients know all of these may cause some degree of weight gain. We can put you on a medication that's not as likely to cause it, but it still may happen. If we present it as this won't cause weight gain, that's inaccurate. And if the patient happens to be one of those folks who gains 50 pounds on aripiprazole, your credibility is significantly damaged. So something to definitely keep in mind, because I think the way that some of the medications have been positioned market-wise has been they're more weight neutral, which isn't necessarily true. I wanted to include this. So this looks at a handful of the newer medications. So asenapine and iloperidone were on the old one, but brexpiprazole and cariprazine are two of our newer agents. As you see, most of them are going to cause between 1 and 3 at the upper end kilograms of weight gain. So you're talking about 2 to 6 pounds of weight gain, and it can be over the course of between 12 and 52 weeks. The first set of bars, so there's blue bars. I don't have a laser pointer, and you probably wouldn't be able to see it anyways. Those first set of blue bars that are asenapine, the first one is short-term, 12 weeks. The second one is greater than 12 weeks, and that had data that went up to 52. The next 2 bars that are red, so the first bar is iloperidone short-term, the second bar is iloperidone followed out for the full 52 weeks. So you'll see 2 colors with the exception of cariprazine, because I only had pooled data for that particular group. So as you see, we'll see a little bit of a change, but for the most part, you're talking about 5 pounds of weight gain in most patients that we could see within the first couple months of therapy. Why might that make a difference? 5 pounds of weight gain, depending on what the patient's baseline weight is, may be enough that their clothes now are uncomfortable, that they're starting to feel the effects of that weight gain. And some of the suggestions are that it's due to a problem with satiety. So patients are not feeling full, so they'll continue to eat. And then if they adjust to having larger portion sizes, even though it may not necessarily be direct effects of the medication itself, but their portion sizes continue to grow, so they could continue to put on that much weight the longer that they're on a medication. So even though this really only goes out about a year, if you're talking 5 pounds every year, that can add up relatively quickly, especially in some of your patients who may have been at the upper end of their weight range to begin with. I wanted to take a look specifically at children and adolescents. So we have 2 medications, aripiprazole and risperidone, that we can use for behavioral disorders and autism spectrum. So this was really the cleanest look at a pediatric population. So I have 1 slide for each. Aripiprazole and its weight changes. They did have clinically relevant weight gain in the pooled meta-analysis. So they included 2 trials. It had quite a few hundred patients in there. They saw a significant mean difference in weight compared to placebo. So they're gaining about 2 pounds more than placebo, but the body mass index didn't change. So even though, yes, they technically weighed more, their BMI didn't change. The way that this gets framed is there's not a clinically relevant effect of aripiprazole on weight. I guess I would argue that there still is some degree of weight gain, so it's something we want to be mindful of, even if we're using this thinking it's going to have less of an effect on weight overall. So it's definitely still there. With risperidone, we also saw an increase in mean weight gain. So this numerically is higher than the aripiprazole, so they may gain a little bit more. So 2.7 kilograms as opposed to 1 kilogram that was seen in the placebo group. Again, there's variability within the groups, but both of them more than placebo. So definitely something that we need to be mindful of. So that may be a reason both patients as well as parents or caregivers may be concerned about being on one of these preparations. Some of the recent literature is looking at, can we add other drugs on board? It really would be argued we don't want to treat a side effect with another medication. So 5 to 7% change from baseline in their body weight, that would be the threshold where we then want to consider, should we change to something different? Is there another medication that would be equally effective that may not cause the same degree of weight gain in the patient? So that would be the threshold to start thinking about changing to a different agent. The other big set of adverse effects really was kind of the impetus for getting our second generation, and it's the extrapyramidal side effects. So these have not gone away, even though they haven't been the focus of much of the marketing with our second generations. So there are different types of movement disorders that can occur. They're more common with our first generation than with our second. When you first start therapy, we worry about acute dystonic reactions. Then we worry about akathisia, pseudo-Parkinsonism, and dyskinesias we worry about a little bit later on. So that dyskinesia part that we see later in therapy, that's really the one we're going to focus on. And just a real quick reminder, so the dystonias are those sustained muscle contractions. So that letter B up there, it's almost like you're trying to put your chin to one shoulder and the back of your head to the other shoulder, and you're not doing it on purpose. So that can come on relatively abruptly, and it can be very, very uncomfortable for patients. Your akathisia is the restlessness, which can be very problematic, but that tends to cause some discontinuation a little bit earlier in therapy. The pseudo-Parkinsonism sometimes tends to be hidden a little bit, so they may have a masked face, they may develop a tremor, their gait may change as they're walking, where they're a little bit less steady, virtually no arm swing whatsoever. So we tend to pick that up when it's more pronounced, especially in elderly patients, because we're looking for it. But I would argue you can see it in quite a few of your other patients too if we're watching for it. But dyskinesias, especially the tardive dyskinesias, irreversible muscle movements, often starting in the face or the upper extremities, tend to be the biggest concern of long-term exposure to the antipsychotics. And second generations are not excluded. So this is also looking at that meta-analysis. So 0 is the line across the bottom. Every single antipsychotic causes some degree of extrapyramidal side effect. Clozapine is by far the least likely to cause those. So in some patients who have pretty significant tardive dyskinesia, those would be the agents we'd be looking to utilize. So your quetiapine, olanzapine, and clozapine. Agents that tend to be a little more prominent with the extrapyramidal side effects are risperidone, and then your first generation agents, including the haloperidol. So those would be things to definitely be keeping in mind. In our younger patients, we may not expect to see movement disorders, but especially if they have a mood component, they may be really sensitive to these and may develop them earlier than we had anticipated. And once they're there, there is a risk that they may not go away. So it is something we want to be very sensitive to. So what did this look like in that pediatric population? So this was the meta-analysis on aripiprazole's use for autism spectrum disorders. There was no difference in EPS seen between aripiprazole and placebo. So they didn't see an increase. But when you look specifically at the trials themselves, there was a 7% incidence of EPS in both the aripiprazole and the placebo group. So it wasn't that nobody had movements, it's that placebo and the aripiprazole group had the same amount of movements. So there is some discussion, is it part of the behaviors that we see or that they were capturing with that? That's a possibility, but with the risk of that being irreversible, I would say it's not something we can ignore. Just because it's not more than placebo doesn't mean it wasn't there at all, and it is something we need to be paying attention to. As expected, it was more prevalent in the risperidone group, although there is a relatively significant variability that's been reported. So in one of the larger trials that first looked at risperidone's use for autism spectrum disorder, they saw that there was no difference between risperidone and placebo. So 12% of the risperidone patients and 6% of the placebo patients had dyskinesias, so some of those motor movements. 14% had a tremor compared to, oh, and I apologize for the typo, 2% in the placebo group, 10% had rigidity, and 2% in the placebo group. So even though numerically those percentages were higher, when you looked at the actual sample size, it was about 6 kids as compared to 3 kids. So statistically, it wasn't different. When you pooled a number of those trials together, so the meta-analysis actually looked at 3 different trials, they did not have enough power because they measured movements differently. They didn't all use the same scale. So one of the trials that they had in the meta-analysis reported more than double the rate of EPS with risperidone compared to placebo. So just under 30%, so a third of the kids were having extrapyramidal side effects, but over 10% of the placebo kids were also experiencing this. In another trial, there was no difference between the two, and the incidence was about 5%. So I think risperidone, it's a little bit of a muddy picture. In some patients, it may not be relatively prominent. In others, it may make it much, much worse, but it's definitely there, even in the patients who had placebo. So we want to be paying attention to this, capturing it, and making sure we can track it over time. So maybe the risperidone's helping the behaviors, but are we making sure that we're not creating a movement disorder that the child will never get rid of? And are we able to tell change over time? So we want to make sure we capture that in our notes so that we can watch and evaluate when would be a good time to maybe discontinue or back off on the dose of some of these agents. So there's one other consideration. So this is a personal interest of mine, but I think it's very, very relevant for the young adults that you may be caring for. And that's looking at the role of hyperprolactinemia in patients who are on antipsychotics. So our antipsychotics are not specific. So they'll block dopamine receptors, and they'll block them in every single dopamine pathway in the brain. The tuberoinfundibular pathway, or prolactin pathway, is no different. So you block the dopamine receptors there, you can get an elevation in prolactin levels. Elevation in prolactin can cause some breast enlargement, it can cause amenorrhea, but it can also diminish sex hormones. And I bring this one up because if you have younger kids who are put on the antipsychotics, we do not have very good information on what the effect of these antipsychotics do to kids who then need to go through puberty, and what those long-term implications are. By diminishing some of the sex hormones, so estrogen is cardiovascular protective. It also seems to have a benefit in increasing bone mineral density. So if we have lower levels of that, does that mean that our younger female patients may be at a higher cardiovascular risk? They may be at a higher risk for fractures and osteoporosis or osteopenia way earlier than what we would have anticipated. So I put these up here as potential consequences because I think this is, full disclosure, I tried to do this as a research project when I was a resident. The sample size you need to be able to determine this is hundreds of thousands of patients. We don't have that information yet. But I think this is a really good example of we want to make sure that the potential consequences of the side effects of the medications that we're using have to be offset by these medications being effective. So we're not sure if it has an effect, so we better be really sure that there is efficacy, that it is improving whatever symptoms we wanted it on board for. So that's my little kind of teaser. I want you to think about it because we don't have good data at this point. And there's a significant difference between them in the prolactin elevations. So agents like risperidone and paliperidone actually are very significant in increasing the prolactin levels and do it much more so than many of our other agents. Some of the newer medications, brexpiprazole, aripiprazole, quetiapine, and asenapine, they tend to be have a much lighter impact on the prolactin. They don't bind quite as tightly, so we don't see as prominent an elevation. So this may be one where if we are starting to see some of those symptoms, it really would be beneficial to switch them to something different. So just to wrap up, side effects long-term are definitely problematic with the antipsychotics. The two most problematic agents that really seem to cause consequences long-term are weight gain as well as the movement disorders. But I would argue that those probably aren't the only ones we need to worry about. So it's important to make sure that we're constantly reevaluating whether this is an appropriate dose and if that medication